This is the panel discussion in regards to the top abstracts submitted to this conference. This session was envisioned as a fireside chat, bringing in individuals with different perspectives, including the clinical, the research, as well as the persons with lived experience. And so we're delighted to have with us today to lead the discussion, Dr. Jillian Walsh, who is a general internist from Calgary, who sees patients with long COVID. Dr. Satish Raj, that's a programming change. He's filling in for Dr. Manali Mukherjee, who couldn't be with us today because she is unwell herself. And he will be speaking. He is Dr. Raj is a cardiologist from the University of Calgary, and he will be wearing the researcher hat to channel Dr. Mukherjee. And finally, last but not least, we have Kara Kupp. She is a pediatric physiotherapist, and she will be speaking from the perspective of an individual with lived experience. So without further ado, I will hand over to our esteemed panel.
So thank you all. Just to give you a sense of the overview of how we'll be doing this, we're going to do the three sets of presentations. So each speaker has been asked to highlight two posters that really resonated with them as an individual in theory in their role as a patient with lived experience, as a clinician treating patients in the community, and as a researcher. But obviously we all bring our own prior lived experiences to it, and so a little more has fit into that. But so each speaker will have 10 minutes to discuss the two things that really spoke to them. We'll have a brief interaction amongst the panelists for a few minutes and go on to the next speaker. So that'll take the bulk of the time, but we've purposely planned it so there is time at the end. So we are hoping to get feedback from all of you on what science, what posters have really resonated with you, what's important, feedback on what was chosen, or if you think we missed the mark and there's something else that really spoke out to you, we do want to hear it. With that, I'm pleased to introduce our first speaker, Ms. Kara Kupp, who is a physiotherapist, has a background as a pediatric physiotherapist, and has worked for Alberta Health Services for over 3 decades. She is not here in that role, however. Unfortunately, she contracted COVID in March 2020 in the first wave, and she's been living with long COVID since that time, so now 4.5 years. She has the potpourri of conditions that we see in patients with long COVID, issues with dysautonomia, with postural orthostatic tachycardia syndrome, or POTS, ME/CFS, and arthritis that is thought to be post-viral and inflammatory. So because of the constellation of symptoms, she's unable to work and currently on permanent disability, and that's the perspective she brings. What energy she has, she is investing in advocacy and education around adult and pediatric, well, children, I guess. I was going to say pediatric patients, but children more broadly who live with long COVID. She advises several long COVID groups in Alberta, nationally as well as internationally, and is a member of the long COVID physio peer support team. With that, Kara, take us away.
Thank you. Can everybody hear me at the back okay? I prefer to not take my mask off. Thank you. Okay, so the first poster that I would like to highlight is My Guide Long COVID, an online self-management tool. And I guess, oh, there we go. Okay, and it is presented by Hitan Nayak, I'm not quite sure how to say that, and his team. So they developed this online self-management tool, and they wanted it to be a resource for people with long COVID. They wanted it to be patient-centered, easily accessible, and customizable for individual needs, and that definitely attracted me to it. It was developed by an interdisciplinary team of long COVID clinicians and 3 patient partners. They have translated it into 6 languages now. They have a dark mode for photosensitive users, and they have text or audio options. So I just took a bunch of screenshots to sort of walk you through the online tool. So it asks a bunch of different questions, like how long have you had long COVID? What symptoms are you experiencing? What symptoms do you want to manage? Sorry, this is hard when I can't lick my fingers to fold the page over. And then different topic areas that you want to look at. They do a nice job of introducing what long COVID is. They talk about a number of different areas, the associated conditions that many of us develop with long COVID, such as POTS, dysautonomia, the cognitive dysfunction. They talk about post-exertional malaise. I really liked that they had this one section where if your family physician is being dismissive or giving you advice that you're not sure is correct, how to deal with that. They have a variety of different resources that they reference, and they have a number of different tracking tools that they give, for example. Okay, so in my opinion, the benefits of this online resource is that it's customizable for many different individuals with long COVID based on their symptoms and their specific topic areas that they want to explore. I feel like they cover a good variety of most of the long COVID symptoms and topic areas that are important to us, such as fatigue, headaches, chest pain, cognitive dysfunction, dysautonomia, POTS, post-exertional symptom exacerbation, and they cover lots of excellent topic areas. I really liked that they present the information in smaller chunks, so it's easier for those of us that have cognitive dysfunction to process, and people can go through a little bit at a time so that they can pace themselves through the tool. I really appreciated that it had both text and audio options, and they had talked about that for people with hearing impairment or those who prefer to read, and then for those who prefer to listen. But I also want to point out that it's really helpful for those of us with long COVID that can't process words and can't read. They have a dark mode, which is considerate for those who have photosensitive issues. But also, I think it's really helpful for those of us that develop post-exertional symptom exacerbation just from bright lights. I feel like it has some nice links to credible external resources, and it provides good examples of different tracking sheets, which are very important for those of us with long COVID to try and measure how we are doing over time and figuring out what triggers symptoms for us and what helps us. And I really like that it had notices that came up depending on your response. So when I put that no, a doctor hadn't investigated all my symptoms, then it has this notice that recommends that you contact your doctor and get investigated. They hope to expand the My Guide Long COVID into a national resource that incorporates the Canadian guidelines. And I would also recommend to them to consider trying to partner with the Long COVID website, and maybe they might be able to incorporate this guide with that resource page as well. So that's my first poster. It's not going to the second one.
I don't suppose we have anyone of an AV persuasion. They can magically make this work.
Oh, there we go. Okay. The second poster I would like to highlight is the research priorities in COVID rehabilitation, a framework from the Rehab Science Research Network for COVID. And that is with Kelly O'Brien and quite a few of her colleagues. I believe Kira, Doug, Marina, and Jill were listed as presenters, so I assume they're all here. The aim of this project was to identify research priorities related to COVID rehab from the perspectives of people with lived experience, which I greatly appreciated, clinicians, researchers, community organization representatives, and policy stakeholders. Oh, sorry. Their methods were, they did 5 multi-stakeholder consultations. They had approximately 450 informants across 22 countries, and they collected their data from June 2022 to April 2023. They used a variety of data collection techniques, web-based questionnaires, synchronous discussions, content analysis of COVID rehab research conference presentations, and they asked these 2 questions. So what are new and emerging issues in the field of long COVID? List 2 of those, and what are the 2 to 3 key research priorities that people might have? So the results were a framework of 5 overlapping research priorities. First was understanding experiences of, of episodic disability. Second was assessing episodic disability, so looking at developing tests or screening for post-exertional malaise or symptom exacerbation and patient-recorded outcome measures. And I really appreciated them looking at trying to find tests or outcomes that don't cause us to be worse and that take the symptom exacerbation into consideration. There's still many agencies like WCB and insurance providers that are asking us to do inappropriate testing that makes us worse. So I feel like it's really important that we have outcome measures that don't do us harm and do show objective issues. As well, they identify and examine safe approaches to rehab. So again, that is super important to me. Looking at symptom titrated approaches and self-management and pacing. They looked at the role, implementation, and impact of the models of care. So we've seen quite a change in our society since things came on in 2020 with regards to in-person, telerehab, group-based, et cetera. And the 5th was examining access to safe, timely, and appropriate rehab. The framework highlights the importance of community and patient-led and engaged approaches and provides a foundation for future COVID research ahead. So why is this important to me? There's still a great lack of knowledge and gaslighting about post-viral illness and long COVID in, unfortunately, healthcare and in the public. People with long COVID, the one thing that I hear from so many people is they really want their physicians and other healthcare providers and insurance providers to learn about long COVID and understand what safe rehab is, and that graded exercise therapy and traditional rehab approaches can be harmful. Many of us wish we had not been advised to push through our symptoms and try to exercise ourselves to get better. Our symptoms were not from deconditioning, but that definitely was thought in the beginning. I really like that this targets not only adults, but children, parents, caregivers, partners, because when you get long COVID, it doesn't affect just you, it affects your entire family, your kids, your spouse, your parents. It has a great impact. And they propose to build on foundational knowledge, lessons learned, and resources from those with lived experience. And I feel like it's so important for us to recognize and learn from the MECFS community because they've been dealing with this for many decades and they have lots of knowledge to share with us. And lastly, for the future, they hope that this will enhance rehab evidence, enhance learning among current and future healthcare providers, and I feel this is critical to try and get this into our physio schools and medicine schools and people learning this in undergrad as well as doing what you guys are doing today. So after you start working, the education for that. Sorry, word finding problem there. And they hope to translate this into clinical guideline recommendations, and they hope to develop policy and programming to enhance function and well-being for people with long COVID and their caregivers. So there were lots of really good posters. It was hard to pick two, but those are the two I chose.
Thank you, Cara. Jillian, any initial thoughts?
Thank you, Cara. I know there's lots of clinicians that have long COVID. I don't, so I always appreciate your perspective. I just had a question about the My Guide. It would be lovely if we could have it more like national. Do you think there's anything missing to scale it up? Like, were there topics missing or any features that you would think might be helpful for people?
I think it covered actually most of the topics. Like I feel like they did a really nice job. I don't know the people at all, wherever you are. I think they did a really, really nice job, and it covers quite a few of the subject areas. I'm just trying to remember. I'm not sure if there's anything about MECFS on there. And the other thing would be MCAS. So I don't suffer with MCAS, but there are lots of people who have mast cell activation syndrome, and I feel like that's an area that a lot of us don't know about. And maybe they could expand into pediatrics, because there are a number of topics in kids with long COVID and syndromes that they get that adults do not get. So it would be really nice if they went into that and talked about things like PANS. And MCAS. Yeah, that's probably what I'd say.
So let me follow up on the My Guide issue. So you talked about things that could be added, right? But in terms of scaling up to national, this is an online resource. This is a phone app or web-based or?
You can look at it on your phone or on your desktop, yeah.
So unless it actually is.
It's not an app, as far as I know.
It's regionally centric, saying, hey, there's this clinic down the street.
No.
Why is it not scalable today? Like, I don't understand. If it's online, what's stopping, someone in Vancouver or Halifax accessing it? So what you've said is, hey, this is a great tool. These things could make it even better, but that has nothing to do with scalability, right? Scalability is we're providing local clinics and we need to figure out how to get that. If you're not doing that, what's to stop it from tomorrow being international?
I don't think there's anything stopping it. I think it's an excellent resource that has lots of good things. There are a few avenues that would take you to something that is more BC specific. So they might want to look at expanding to things that are more national specific or international. But with regards to the general knowledge that it covers and the different topic areas and the different symptoms, I think they've done a really nice job with that could apply to anybody.
Okay. Any other questions, Julian? Or?
Any questions about the second poster?
Do you have questions about the second poster? Or?
Well, I think we get to be in the privileged position to provide a little bit of our own opinion, just being up here. And so while it was like extensive stakeholder kind of consultation, was there any research priority that you thought should have been in there that wasn't? And also your experience as a physiotherapist.
Yes, I am a physiotherapist, so safe rehab is really, really important to me. And just the number of individuals that I've come across with have been advised to do very unsafe rehab techniques. So I think one of the biggest messages as physio and as a person with lived experience is to get the message out there about learning about what safe rehab is. Unfortunately, I think there's still people out there who are using graded exercises and pushing exercises or assessments that do damage and make us worse. From my point of view, when it's looking at rehab, I feel like they're touching all the important parts that I think are important. I really value that they're looking for the patient voice. I really value that they're trying to find assessments that will show objective measures of how we're doing without harming us. I feel like it's really important that they're looking at the post-exertional symptom exacerbation, and they're looking at it in all of the different environments. So no, I don't think I would add anything else to that. I think they're both really well done. So.
Thank you very much, Cara. So our next perspective will be that of a practicing clinician, so a theoretical front lines perspective. Dr. Gillian Walsh is a general internal medicine specialist with AHS. I haven't had a lot of trouble figuring out where she works because she seems to work everywhere and be on call in different places. She is or was in Calgary, but I think is on call today in Edmonton as well. So she's sort of, everywhere. She has a master's in health economics from the University of York, not to be confused with York University. This one's in England as opposed to in the Greater Toronto Area. And she has appointments both at the University of Alberta and University of Calgary. So she was the medical director for the southern half of the province's COVID's IPOP program, interprofessional program for long COVID. I say was because, as many of you will know, the funding for that, I think, abruptly disappeared a couple of months ago. And so if you're trying to figure out what is going to happen in the future, Gillian may know, I don't, and maybe she'll address that as well. With that, no pressure, Gillian, go ahead.
I'll try and do this with my mask on. I'm going to blame being on call for the spelling mistake that already exists on the first page there that should say top abstracts. But I do want to highlight that, it was, as Kara said, really hard to pick. And so I tried to put my clinician hat on and say, kind of, when I'm seeing patients, what would be things that I'm looking for? And kind of, I thought, well, maybe something that targets the underlying mechanism. So looking for a poster that maybe talked about that as a treatment option, and then also kind of the rehab side. So those were the two hats that I was wearing as I looked at posters. So from a treatment perspective, as I've been treating post-COVID condition or long COVID, I'm going to use those interchangeably, I'm finding that most of the stuff that we used to treat is very symptom-based, so we're targeting symptoms. There's not a lot of actual pharmacologic agents that are treating the underlying cause. And that's frustrating, because sometimes people say, well, am I going to have to be on this for forever? And while there are trials coming out, a lot of them haven't been overly successful. They've borrowed from kind of ME/CFS or chronic pain and said kind of maybe try these things, but arguably haven't been specific to COVID or have thought to have a theoretical benefit against, say, inflammation. And so why is this? Why has it been so hard? I mean, you guys know this, I'm just repeating, but multiple different mechanisms have been proposed, and I sometimes wonder if it's like we can treat one thing and then another thing gets worse, or we treat one thing for somebody and somebody else's COVID symptoms are related to a different kind of underlying mechanism, so different causes for different phenotypes. I will say, I just wanted to highlight that this paper did come out in the fall, and it's going to be relevant here in a second with the poster I'm talking about, looking at the fact that we did find that people have serotonin reduction in the post-acute sequelae or the post-COVID condition. And the only reason I'm going to highlight this is that basically they said, well, here's something that might actually kind of fit all these pathways or have an implication in all of these pathways. And so maybe there's some actionable insights here. And they specifically looked at serotonin and tryptophan, so keep those in your mind because they will be important in a second. So the paper I'm going to highlight talks a little about taurine, and I'm not sure people walking down the street know what taurine is, so I had to do some research, but basically it's an amino acid. It's found in higher concentration in excitable tissues, so nervous system. Cells deficient in taurine often are pathological, so they see them in several different disease states. And we know that taurine, through various mechanisms, has cytoprotective activity. So it's a protective agent in the nervous system. And so taurine has been studied in other conditions. A lot of the studies so far have been in animal models. So when people say, oh, it works for this, a lot of it's been animal models. They're starting to look at things in humans. Mostly the kind of positive studies have been around measuring taurine, so saying like this is elevated in this disease state. We're only starting to look at whether there's benefits of supplementation, and there's been some mixed results so far. So one that comes to mind was looking at it in stroke, and kind of it was mixed reviews. They do see benefit in diabetes, obesity, and metabolic syndrome. So I just want to caution everybody, taurine seems to be like a popular topic these days, and people are talking about it all over. So I always caution people that I'm not saying this is like 100% a slam dunk answer, but it's definitely interesting. So I'm going to talk a little bit about this poster. So I apologize. I am going to say the first name of this person wrong. So these lovely researchers from the University of Alberta did this poster, or did this study on plasma taurine levels in the post-COVID condition. And what I took away was three main highlights: that taurine levels in long COVID, like they looked at taurine levels in long COVID patients, they correlated them between symptoms and the level of taurine levels, and how did these change between the acute and convalescent stages of long COVID. So they looked at these patients, 256 patients, they did blood kind of at the acute phase, waited 6 months, did blood again. At the kind of 6-month-ish mark, they did a symptom review, and then they actually looked at kind of clinical outcomes or adverse events up to 17.4 months post. And with both of these blood samples, they took them, they did all sorts of bench research, fancy things. I apologize, I don't know them all. And basically found that taurine this shows the difference between normal individuals and diseased, or people with post-COVID, taurine levels are drastically different. Note also that there is serotonin that shows a big difference between the two groups. So I thought that was interesting that this is coming out in further research. Again, this I'm just going to quickly go through. We see that there's only a positive correlation with taurine and tryptophan and serotonin. So again, seeing some common themes, which I thought was promising. Here we see that taurine levels were lower in the acute phase and improved or went up in the convalescent phase. And that we also see that people that have events, that kind of the clinical events we were talking about, had lower taurine levels, was associated with. That this is just kind of showing the people that had events and the people that didn't have events, how their taurine levels changed over that period of time, and also kind of taurine levels relative to the severity of symptoms. Koramju, I'm so sorry, and company have done this kind of great poster. I would, look into it further. It's very well done. And I just wanted to highlight that because I think there could be a possible treatment option coming out of that.
Did you just cut yourself off?
What?
Is that, oh, no, I thought you beeped yourself to an end.
No, sorry, I'll answer it after. I'm gonna turn it off though, because it'll go off again. Sorry, guys. Anyways, the other, from the rehab perspective, I found this poster, I was looking for a poster kind of to talk about that, because I think virtual care is becoming a critical aspect of treating patients with post-COVID condition because of fatigue and just accessibility.
You can have my page or two if you're collecting.
There's a growing body of evidence suggesting that non-pharmacologic management is going to be key. I think you guys already know that. I'm not telling you anything you don't know. There's guidelines out there suggesting that we need it to be very tailored, so to address individual needs, physical, psychological, psychiatric, and that potentially for the right group of people, low and moderate intensity resistance and endurance training programs can be helpful. I do say that with caution. There's not a lot of randomized controlled trials, so that's why I wanted to highlight paper completed. I realized I didn't take a picture of the paper. We'll get it up after. They randomized 132 people to intervention and control. The demographics were actually really similar to the patient population that I worked with, so I thought that was really good. And basically, you got randomized to usual care and an 8-week virtual rehab program, or usual care. And then they kind of did an assessment at 8 weeks and monitored your healthcare utilization for 12 weeks total, so 30 days after that assessment. This was just an example of some of kind of what it included, and I really liked that it had the educational sessions, but also the exercise sessions, and that I also think it's nice that they start with more supervised sessions and then over time kind of build up some confidence and ability to potentially do things unsupervised. So this is a big kind of results page. I'm going to make it easier for us to see. So they did see some improvement with regards to fatigue, dyspnea. They looked at pain using the EQ5D, which is a validated kind of quality of life score. They also looked at some improvement in function, or saw some improvement in function, and overall kind of total disability index did improve for some patients. The rest of the findings just didn't meet statistical significance. So I will say that there are some important considerations to take away, even though I thought this was really exciting, that there were 25 participants in the intervention that did not progress through their training in terms of staying on schedule with intensity, duration, and type of exercise. And there were people that had definitely related, because sometimes we don't know, adverse events reported, mostly post-exertional malaise. None were severe, but there was still quite a few that were mild or moderate. And so I think this just makes me kind of remember that, well, we can have these virtual programs potentially, and maybe that's what this is telling us, that we do maybe have to consider that there's going to be certain subgroups that need a little bit of a different approach. They specifically kind of mentioned people with cardiovascular disease, but also those that suffer from post-exertional malaise, both kind of from mental stress, but also from physical stress. So yeah, I apologize the poster was missing, but other than, I thought it was still really well done. So I'll try and pull it up here.
Cara, initial thoughts?
Yeah, so first of all, with regards to the taurine poster, I'm very curious to see how taurine is going to impact people with long COVID. The one question I had is that it includes inpatients, is where they picked up this population, and I know that sometimes people who have experienced COVID as an inpatient are a bit different than those of us who were barely sick and developed long COVID, so I just wasn't sure if that would make a difference or not. Yeah, I think it gives hope that maybe there might be something out there that will help us. I just want to point out that those of us with long COVID are pretty desperate to find anything that will help us. And I feel as long as we are looking at the risks versus the benefits, yeah, it's definitely worth giving it a try, and it doesn't seem like there's any significant side effects of supplementing with taurine that I could see there.
I don't know that the poster commented on that. Like, we get a lot of taurine every day, fish, meat, energy drinks have taurine. So I think it's one, looking at the form it comes in, because I know, for example, like energy drinks might make you tachycardic, could make some of your symptoms worse. So just taking that into consideration and just being very clear that so far we have no studies that actually say that it's supplementation changes things. It may have to do with absorption of things like tryptophan or serotonin at the gut level, because generally most people are able to absorb enough from their diet. It's probably something in the pathways that's kind of breaking down. So I agree with you though.
So I have a technical question, and we may need Gavin or his team to answer it, because I may have misread one of your slides, but it looked like there was a slide with control, so levels, control, and two groups of patients that recovered acute or convalescent or something like that. And the control levels were close to zero. And then everything else afterwards suggested that lower taurine levels in the affected group was worse. So did I misinterpret that? Because it's, I'm not sure why we're supplementing if the healthy controls were.
I think there was a graph that's, I don't know if I can go back, that was looking at the difference. So it's just a graph of the difference between the not control group and the people that had post-COVID. So it looks high.
You want to see if you can?
Oh, perfect. I assume it's this graph here. Nope.
Well, okay, so this actually, well, even this looks like there's more, right? More than what?
So this is just and again, I'll defer to Gavin and his crew, but my understanding of this graph is that actually it's just looking at the difference between controls and taurine. So
Right,
they're saying
but who has more?
the biggest, so the controls would. The biggest difference they saw was with glutamic acid, but also serotonin and taurine had large differences between the control group and the patients. So it's just it's measuring a degree of difference.
So high is deficient and low is?
High is starkly different than the control group, lower.
Go to the next slide. Oh, so one after?
Oh,
Okay, no, this one on the left.
okay.
This is a plasma level of taurine, and the control level is somewhere around 30 as far as I can tell from this. And the patient levels are all above 100.
Yeah, I'll have to defer to Gavin on that one.
Okay. Right, so I bring this up because afterwards it looks like there are differences with events, right? But if we're talking about, where I think this is going is, should you supplement? Is this going to be a treatment? It's, at least, so I guess I should, I'll lay my cards on the table. So I come at this from a researcher perspective and a very skeptical researcher, right? I've lived and been in science long enough that for the prevention of cardiovascular disease, I've lived through homocysteine causing all cardiovascular disease and folic acid was going to cure it. And then there was vitamin C at one point, vitamin E at one point, vitamin D I think we're just about done with, right? So, there's a cycle of things that are apparently low and you try and replace it and it doesn't work. So I come at this with any replacement saying it should be studied, but here I'm not sure whether we're trying to increase it or we're trying to decrease it, because the levels and the controls seem to be low and that would seem to be a good thing.
So I'm not sure that I fully understand the graph, so that's what I'm going to defer to. But like the overall idea is that we're seeing low taurine levels in this patient population, more so in the acute phase and more so in people that have events relative to people that don't have events. I'm skeptical too. I don't think we can just go and take taurine. I think this is just kind of preliminary research that suggests that there might be some targets out there, but it's more complicated than just supplementing taurine. So yeah, I don't know if I answered your question. But I just wanted to take a moment, sorry, because I feel terrible. The second poster was out of McGill by Genotis Ferreira, Dr. Genotis Ferreira, and it was virtual rehabilitation in long COVID, a randomized control trial. So please take a look at that poster because I thought it was well done.
And I just wanted to comment on that poster. Jillian and I had a good discussion about that poster, and of course, my feelings as a patient with long COVID, as well as being a physical therapist, is to talk about safe rehab. And I totally understand from her point of view, she wants and needs somewhere that she can refer her patients to get safe rehab. And I certainly want people to be able to access that too. I appreciated that they spoke about PEM with regards to their virtual program and that they talked about an individual approach and careful monitoring, but I thought it was quite interesting that 25 out of 65, that's 38% of the people were unable to progress in their training programs. So I feel like that's quite significant and tells you that what they were doing was quite a bit and maybe too much. And again, as she pointed out, 34 out of 65 participants experienced 50 adverse events. And from what I could see in their education program is they weren't talking about the resting and pacing strategies that are really important to incorporate into our self-management. And I'm not sure that I would have been able to do their program for probably the first 4 years of my illness. It didn't really talk about what they were doing for the aerobics or strengthening activities, but when I was first sick in the first couple of months, when I didn't realize that exercise wasn't good for me, I just did 10 bicep curls with a 5-pound weight, and I had intense chest pain for days afterwards. And then I would also just be curious to know if the acceptability and adherence rates were taken from the 40 that were able to continue, or whether it was taken from the full 65.
I would love to know that too, so if somebody's here from that group and wants to help us out. There was stuff about the exercises, but it was just so small that I couldn't actually include it, but it did sound like it was very gradual, like starting out with just stretching. So yeah, I think it would be nice to know if even if you couldn't progress at the rate of the program, if you still found benefit from the program.
So I see there are people wanting to ask questions. We actually have one more set of presentations, but I guess the question is, are your comments or questions to respond to slander and libel that may have come from here? In which case, maybe I'll let you guys go ahead. If it's to broaden the discussion, I'd ask you to wait until the one more pair. But
it's for the first one you discussed, so I can go sit down, because I too have long COVID and I don't remember well, and standing's hard. Dr. Odette, his work is very important and the findings are important. We need to remember that correlation's not causation. Most people die in a bed, and the body recycles taurine as well. But the first time I heard his talk at a long COVID webinar, I went to my pharmacist and said, okay, where on your shelf is the taurine? Because I too, like you, am desperate. If horse dung worked, it'd be in my meds bag. And I did speak to someone who works with long COVID patients who said they all went out and bought taurine. And they talked about the effect they didn't see or did see. Are there any long COVID clinicians among the 500 listening to us at home or in the room here who are willing to stand up and talk about the effect on their patients? And I'll give the mic to Dr. Odette, as he's the one who knows this work best.
Yeah, great. Thank you. Thank you for that. So, and thanks for highlighting the poster. So, no, absolutely. So, intriguing finding. So, I just want to highlight this was a completely unbiased finding with machine learning and things like that. So, this was not what we predicted. The signal is strong in this cohort, so it does go up with COVID, but again, patients that had a lower increase in taurine levels had more events. So your inability to increase your taurine is what was linked to worsening events. So absolutely, it does go up. The basic science, we'll talk about this at the afternoon session, is quite strong. And it also may also help in things like chronic fatigue syndrome. So we did receive a 3-year CIHR grant, very fortunate to have with Angela and the Reclaim platform. So that protocol is now being written, and hopefully we'll be able to start here in a few months. So we are actually going to test causation here with taurine. We are going to do a biomarker part of this, so to actually look at how patients respond to taurine supplementation and how that's tracked with potential clinical benefits. So we will have definitive answers. Thank you.
And please go see his poster, because there's lots of graphs that I didn't have the time to highlight that I think are valuable to look at.
great. Can we get Manali's slides up? So the final presenter offering the researcher perspective is supposed to be Dr. Manali Mukherjee from McMaster University. She got sick, and apparently she's been very ill for a couple of days, and so she wasn't able to get on a plane yesterday. We were getting lots of emails trying to figure out whether she'd be well enough to get on the plane, but that didn't seem like a brilliant idea.
So I'm substituting for her. So this presentation will necessarily be shorter because what I'm going to present from the researcher perspective is what really appealed to her. I take it I need a slide mover thing. So what really interested her, I think, well, let me take a step back. I think from a researcher perspective, what has fundamentally been lacking isn't the concept of, patients got COVID and then they have an illness afterwards, but why, right? What is the pathway to get from, this viral infection to illness? Is it persistence of specific proteins? Spike proteins been blamed a lot. Is it an inflammatory reaction trigger that goes on? Is it, clots, endothelial dysfunction? There are lots of things that have been thrown around. That's one thing. The other thing, and this is partly a researcher perspective and partly a clinician perspective, is that many disorders, and this is not unique to long COVID, but I think common in a lot of, certainly in post-virus related disorders, but probably in other disorders as well, the lack of a biomarker, the lack of a test. It doesn't have to be a blood test, but blood tests, doctors are good at ordering blood tests. But the lack of a blood test to say, you have something that is clearly associated with this or clearly abnormal, right? We have a normal range and this is clearly not there, is limiting, right, and is lacking. And I think that's the perspective that she came from when trying to understand this. So there are two posters, both related to immune mechanisms in long COVID and inflammatory mechanisms in particular that really spoke to her. This first abstract is from Bedard Matteau and al. From Dr. Rousseau's group, and it was basically looking very specifically at their favorite interleukin. Interleukin 17 or IL-17 actually has a lot of interesting roles in its relation to cardiovascular outcomes and hypertension in particular. There are different subtypes, but they actually, and this has to do with their role in affecting endothelial function, right? So it's a cytokine, an evil humor, if you will, that actually does impact endothelial function, impacts neutrophils, and the expression of a protein called ICAM1. And what they found is that a specific subtype of IL-17, so IL-17F and not IL-17 alpha, was elevated in their long COVID cohort, the severe long COVID cohort. And they mapped out a pathway where that cytokine, IL-17F, actually derived the expression of ICAM1, right, which is known to correlate with endothelial dysfunction. And in a cell model, so not in humans, this is an isolated cell model, actually promoted the adhesion of neutrophils. So a pathway for sort of inflammatory effects and endothelial dysfunction. And this then, may have implications more broadly than long COVID to the broader issue of ME/CFS. So a mechanistic pathway that carried forward. So I will leave that alone. I hope there are people related to these posters that can explain this more scientifically. I mean, I'm a cardiologist, human cardiovascular physiology I can do. Evil humors I'm not as good at, right? They all, well, half of them start with IL, and I can't tell the difference between one and the other, but there are lots of smart people here that probably could. The second issue is actually the evolution of long COVID or the post-COVID condition over time. So what happens, as you get further away from the infection, specifically what happens with inflammatory markers. And so this is a cohort that was followed from the beginning and then over at 3 months and 6 months. And so you had an opportunity to look at who recovered and who didn't, right? So this was from onset of COVID, not onset of long COVID. And they developed a model, and basically they determined, with an algorithm that developed risk factors for developing the post-COVID condition or long COVID. And some were clinical, but many were related to specific
markers. So the CDs are all sort of markers identifying different types of cells in the body. There were separate patterns that they were able to come up with based on cluster analysis. Right, so basically, what they've concluded is that there's actually immune dysregulation seen in the group that developed a post-COVID condition or long COVID, while that wasn't present in the group that didn't develop it. And again, ultimately suggesting that the fundamental issue is an immune regulation, autoimmunity problem as the primary pathological mechanism. So this doesn't map out everything on the way and explain it fully, but it certainly is showing smoke in that pathway, suggesting that that's the underlying problem. With that, I have nothing else to add. So, Cara?
So with regards to the first poster, I would just say a lot of it was over my head, but the one main message that I got out of it was that I really appreciate that people are looking further into long COVID and that it's not just a respiratory disease, that we're looking at endothelial cell damage and having that be a driver of how your blood flow is and thromboembolic events. So I really, really appreciate that we're not just focusing on respiratory disease anymore. And then with regards to the biomarkers, again, I really appreciate that we're now discovering that this is an immune dysregulation problem and looking at autoimmune issues. I developed post-inflammatory or post-viral inflammatory arthritis after 2 years. So COVID is the gift that keeps on giving. I didn't have it for the first 2 years, but autoimmune conditions are definitely related with long COVID. And I really appreciate that people are looking for biomarkers, but I just want to reinforce again from a patient perspective, there are lots of conditions out there that don't have biomarkers that we treat. And it's just really, really important, and I'm preaching to the converted here, obviously, but that family physicians and specialists and other healthcare providers are listening to their patients and believing their patients when we tell you all the wacky things that are going on in our bodies, because honestly, it's really hard to believe, and if I wasn't experiencing it myself, like, there are lots of really interesting and not so wonderful things that are going on in our bodies.
Totally understand what you're saying. I still think the biomarker thing is interesting in the sense that if we can kind of, for the majority of patients, see these biomarkers are present as kind of identifying people with post-COVID condition, and then look at what symptoms those patients have, we start to get an idea of kind of what are all the symptoms that can be COVID related. Because that's even changed since I started seeing COVID patients after kind of the first wave to now, in terms of what I thought was a symptom potentially related to long COVID and what I have a better understanding of now. And so it's interesting. It would be interesting to know too, different strains, if the biomarkers are different at all, if anybody is from kind of the group that looked at that. So, but yeah, I do hear your worry about if somebody doesn't test positive on a biomarker, are they not going to kind of be believed? But I also think it's really exciting to have something kind of concrete as a clinician, because, you know, there's a lot of conditions out there with some nonspecific symptoms, and then they come and you're like, I don't know if this is long COVID, so sometimes it is nice to have that.
Ideally, it would be really nice if there was something that we had that labels us as having long COVID, because having a positive PCR test doesn't really matter, and, you know, lots of people aren't testing anymore, so that makes it even more difficult to know if people who are having some of these weird symptoms, if they have long COVID or not. So I don't envy all the health professionals and physicians that are trying to figure this out, and we really appreciate all the work that you're doing. But again, we really appreciate you listening to the patient voice and having us partner with you moving forward to try and figure this out together, because it is, a very interesting illness that is not specific. We're all so heterogeneous and we all present so differently, which makes it really difficult.
Great, so we have a few minutes for comments or questions. We'll start on the floor. I don't know if there's going to be stuff online as well, so if someone has stuff online, yell at me, but go ahead.
Sure, thanks. Thank you so much for everybody's opinions and posters. There's some really exceptional work out there. So Kara, this one's for you, because I'm also a physical therapist. You presented the My Guide as being a fantastic tool, and it is, so big shout out to the people who created that. It's amazing. It's also been a destination, though, that lots of people have been directed to, with different specific clinics closing across the country, programs being shuttered, and it's being kind of touted as a substitution for rehabilitation. And so I kind of want to get your opinion on the goal of rehabilitation often is self-management for patients, and then you have a self-management tool. So where do you think the value is for live clinician rehabilitation as opposed to it being an online resource that is touted as a substitution?
Thanks for your question, Lauren. I don't have my glasses on, so it took me a little while to recognize your voice there. I think for people who have nothing and are trying to find something and some general information, I think it's a really nice resource to start. And I think there are many different resources that have been developed in different provinces across the country, and many of them have lots of good information. I do still feel it's important to have contact with a rehab provider who is knowledgeable about long COVID and is giving them that more individualized approach. I think it takes a long time, like me, even as a physical therapist and a healthcare professional, it took me a long time to learn and to realize that I couldn't exercise myself out of this and that I needed to completely stop and start resting and try and get my symptoms stabilized so that I could gradually pace up. So I am devastated that the clinics are closing, the long COVID clinics across the country. I think they are very important, and I really would have liked to see them continue to grow in their knowledge and the services they could provide. And I'm really scared at what's going to happen for all the people living with long COVID, as to how they're going to deal with things in the future.
Lauren, I know you didn't ask me, but I'm going to answer. I think one of the thoughts I had kind of with scalability is, and you kind of alluded to, there may be some more BC-specific resources. I wonder if one of the questions that you get asked, kind of like what are your symptoms, but also could be where are you located, and then could be directed to people that are providing this kind of therapy in person, and then potentially also to virtual stuff that gets kind of more validated.
One of our goals with the Long COVID Physio Organization is we have a safe rehab committee, and they are really looking at trying to develop a list of safe, knowledgeable, educated physio providers or allied health providers. So that definitely is a long-term goal for around the world. But it's definitely a growing and learning experience that we're at right now.
You have an online question?
Yes, thank you. There's been a couple questions about more about knowledge mobilization and how we get these kinds of research findings into the hands and minds and hearts of the clinicians, the educators, the people that need to have this information to care for people living with long COVID and their caregivers. Do you have perspectives or thoughts on how best to get this kind of information into to the right targets, and how? From each of you.
Well, as I highlighted in that one poster talking about trying to get knowledge into our undergraduate programs, and having it be part of the curriculum would definitely be useful. And then I have also had discussions with other people in this room about trying to somehow get the education out to primary care, because that seems to be where a lot of people are having difficulty. Either they don't have a family physician, or they might have a family physician that maybe doesn't understand about long COVID. So I don't have the magic answer to that. It's definitely a goal that those of us with long COVID would like. And I'm wondering if we can start sort of doing more education sessions at, a family physician conference or at an emergency conference through the different professional organizations like the Canadian Physio Association doing more education in that way. But yes, definitely a need.
You kind of asked about some of the things that we're thinking of as we have lost our resources for the long COVID clinic. And I think one of the things that Dr. McKay and I, who have kind of been in the South, are talking about is having some of these education sessions with the family physicians about some of the stuff that we've been doing so that you can still potentially access that treatment. It's still in its early days, so don't quote me. I also just want to highlight Angela and her group, like the long COVID web. I think they have a pillar kind of around knowledge dissemination. And so I think it's coming. I think it takes time to understand how best to necessarily distribute this information, but they're definitely working on it.
Okay, so Grace is trying to cut me off, but I'm going to actually use Chair's prerogative and stay up here to allow one more question. But before that, as the grumpy uncle on the panel, the answer to the question about physician education and the hearts and the minds is it's not going to happen, right? I mean, the truth is, if physician education, I mean, if this was as simple as, oh, we'll do this and the family doctors will do it, I guess I would ask those of you, who interact with people in the MECFS community or in the POTS community who've been going through this for 20, 30 years or longer, why hasn't it happened? The reality is you need to make the resources out there. Physicians will come to it when they're ready, just like patients will come to stuff when they're ready, and if they're interested, they can approach it. You can write all the articles you want in review journals. You can, have all these meetings. The reality is everyone that's chosen to come to this meeting came for a reason, and it is the choir that we're singing to. We're not sort of reaching the people that, that you're complaining about, largely. Maybe you're complaining about me too, but largely the people you're complaining about. And so it's an iterative, slow process where you make the resources available, and people do come around. So in the POTS world, it's gotten a lot more attention as part of long COVID, and so there are more family doctors reaching out, asking questions, but it's not going to be added to the medical school curriculum. Every medical school curriculum is thinning out, not increasing content. Rebuttal?
And I was just going to say that, as our previous speaker about the vaccines, I don't really want to talk about politics, but I think having a government that acknowledges COVID and acknowledges long COVID and supports the education to the public that long COVID is happening and that COVID hasn't gone away would definitely make life different as well.
So I'm going to allow one more question. I recognize that I'm standing in the way of you and lunch. If someone's really hungry, start lining up. But go ahead, final question.
Hi, I'm Dr. Vu. I'm in British Columbia, and I just wanted to clarify the My Guide. It is an educational resource. It is available online. Nationally, it's available. We even developed a new website address, longcovidguide.ca. So it's no longer Long COVID BC, but it's longcovidguide.ca, and it does not replace the therapy, the treatments. This is very supplemental, high-level education resource for people who are unaware, unfamiliar with it, and it's not, it doesn't provide treatment, so it doesn't replace it. That's why it's so necessary to have all of these prongs of education, therapy, treatment, ongoing research, and evaluation.
Thank you very much.
Thank you.
Thank you all. With that,
can I please just make a statement to the speaker about doctors not learning and learning in their own time? I'll be very quick.
sure.
I completely disagree with you. I think doctors need to be brought into the 21st century. They have to learn about long COVID. We have over 400 million sufferers and a projected rate of 10% of every population suffering from long COVID, and this is rising as we continually expose ourselves. We need to get the medical faculties on board. It needs to be in the medical curriculum, and doctors need to be forced to think of it as a differential diagnosis when they are assessing a patient in front of them. We are still in a pandemic, and the fact that doctors do not even think of long COVID when they have a patient present with an illness to them in their practice is frankly criminal. So I am working to change the narrative, and I think all of us here do. Long haulers don't have time to wait. We need to provide, the medical profession should be leading in education and awareness across the world about this disease. And we're not just talking about long COVID from the NECFS perspective, we're talking about a burden of organ damage and possible cancer that is on our doorstep, that will be catastrophic for any kind of health service, never mind a free health service. We need to work to prevent, and doctors need to be educated now.
I look forward to your efforts in that regard.